Hello, medical students. This is Dr. Ron Manny, an epileptologist and associate director of the Neurology Clerkship at Rutgers Robert Wood Johnson Med School. I'm going to talk to you today about seizures and epilepsy. I have no relevant conflicts to disclose. The objectives for today are, first, we're going to go over the anatomy of a typical seizure and classification of seizures. Next, we're going to review the definitions, classification, and etiologies of epilepsy. Thirdly, we're going to discuss the workup done in a patient presenting with a seizure. And then lastly, we're going to go over epilepsy treatments. Let's get started with the case. This is a 36-year-old previously healthy woman who presented to the ER after a car accident. Bystanders were in neighboring vehicles and they saw her car slowly drive into the ditch. When they attended to her, they saw she was unresponsive and her body was shaking. They called 911. When EMS arrived at the scene, they saw she wasn't shaking anymore, but she was confused. She couldn't recall what had happened. There was no signs of trauma, and she smelled like urine. She was brought to the ER soon after, and her neurologic exam was basically normal. On further physical exam, they did note a tongue laceration on the lateral portion of the tongue. So my question to you is, what is the differential diagnosis of a shaking episode? The list of potential diagnoses for shaking is long. One common cause is convulsive syncope, where the person is having loss of consciousness and they have brief shaking during that time. There are many causes of shaking under the category movement disorder, such as tremor, tics, and hemibolismus. Another cause of shaking is asterixis, which is typically flapping movements in the arms when they're outstretched in front of the person's body in someone who is confused, such as in the case of alcoholic encephalopathy or other toxic or metabolic causes. As we're going to focus on today, a common cause for shaking is seizure. Another cause for shaking is ataxia, which is typically seen in disorders affecting the vestibular cerebellar pathways. Another cause of shaking is shaking as occurs in a panic attack, when the patient would feel impending doom or anxiety. So the next thing we're going to focus on is, how do you tell if someone's having a seizure? As we're going to show you, the devil is in the details. One thing you should appreciate is a large proportion of the population has a seizure by the time they reach an elder state. About 10% of people will have a seizure in the United States by the time they reach 80 years old. Some particular features of a seizure are listed on this slide here. Generally speaking, the way a person has their second or third or future seizures in their life is stereotyped, so they'll have the same type of event over and over again. Other features of a seizure are that they're typically rhythmic movements when they have motor manifestations. Seizures are typically brief. They're usually less than 2 minutes long. What a person does in their seizure depends on what part of the brain is involved in the seizure. We have a term for the spread of a seizure called Jacksonian march. What that alludes to is the neuroanatomical progressive spread in the seizure over the brain and over the parts of the body. The picture on the right shows an example. The seizure starts in the mouth and laryngeal area of the motor cortex, that's the lateral portion of the motor cortex, and the person would make a sound. Over the course of seconds, that activity can spread to the face and manifest as facial twitching, and then spread to the hand and fingers area, and eventually to the trunk and leg, and may show as stiffening and shaking in those areas of the body. The next slide demonstrates in cartoons some common behaviors in seizures. In many seizures where the person loses awareness, we'll see the person stare and not respond. They may look confused, and they may make automatism movements, which are semi-purposeful movements in the face, such as pursing of the lips, licking of the lips, and in the hands, such as rubbing of the fingers. If that seizure progresses, the person may have jerking and twitching movements, shaking of their extremities. Sometimes during the seizure or after the seizure, they may wander. Next, we're moving on to the anatomy of a seizure. It's not common for a person to have a trigger to their seizures. However, in syndromes such as childhood absence epilepsy, a flashing light at a certain frequency or hyperventilation can trigger a seizure. Many people will have an aura before their seizure, An aura is simply a seizure with primarily sensory features. Examples of those symptoms are feeling déjà vu or feeling a detachment from reality. What most people think about as a seizure is the ictal phase. When epileptic activity spreads to both sides of the head, that is often where awareness is impaired. The patient may also have stiffening and shaking. This phase is typically self-limited, lasting about 1 to 2 minutes. After the seizure, there's a generic term for post-ictal phase, when the patient has neuronal dysfunction because of the parts of the brain involved in their seizure, and often will discover signs of injury. The patient may experience disorientation. They may also show urinary incontinence if their bladder was full. They may have a tongue bite, as in the case of our patient. There's a term called Todd's paralysis, which is that the patient may have a weakness in a part of their body corresponding to the part of the brain that was most involved in the seizure. Sometimes after a generalized tonic-clonic seizure, patients feel myalgias throughout their body. They feel like they've run a marathon. We also may see a significant increase in their creatinine kinase. Sometimes patients have fractures and shoulder dislocations. These are things to look for after a generalized tonic-clonic seizure. Now let's move on to seizure classification. The two major types of categories for seizures are focal and generalized. The term focal is used when clinical history specifies that a seizure experience begins in a part of their body that corresponds to the seizure focus, which is the part of the cortex where the seizure starts before it spreads to the other parts of the brain. On the other hand, generalized onset refers to that both sides of the head have generally simultaneous onset of the seizure. For some people, we don't know, and that's unknown onset. Further testing will help determine if it's focal or generalized. And uncommonly, it may be unclassified, just as other things in medicine. Next, let's expand on behaviors that occur in seizures. In focal onset seizures, you should understand if the patient has impaired awareness. The old terminology used words such as simple partial seizure, where awareness was not impaired. If awareness is impaired, the term complex partial seizure is used. Motor manifestations that people may show in seizures are automatisms, stiffening of a limb, clonic shaking of the limb, and myoclonic jerks, which is a brief one muscle group action. We alluded to non-motor manifestations in prior slides. They include sensory phenomena such as déjà vu, bad tastes or smells. Sometimes patients will have autonomic changes such as an increase in their heart rate. Lastly, when a seizure spreads from one area to the other sides of the brain, we call that a focal seizure that progresses to bilateral tonic-clonic seizure. The old term for that was secondary generalization. The other major category for seizures is generalized onset. That used to be called primary generalized seizures. As we discussed, those are seizures that start out on both sides of the brain at the same time. Examples of motor manifestations are listed on the slide. Myoclonic jerks may happen in generalized seizures. A non-motor manifestation of a generalized seizure is absence seizure. In childhood absence epilepsy, often an elementary school-aged child will have an impairment in awareness that will last for about 10 seconds. They may have fluttering of their eyelids. After that brief seizure, they will go back to what they were doing just before it. The children in absence epilepsy may have hundreds of these seizures in a day. Now let's get back to our patient. Her basic labs, infectious workup, and toxicology screen were negative. Her head CT and EEG were normal. She was discharged home. She returns to the neurology clinic with her husband. Her husband reveals that she's had 2 events in the past 6 months that were brief. They were about 1 minute each. She was unresponsive. She was staring. She had chewing movements, and she had repeated rubbing movements in her hand. There were no triggers on those days, such as sleep deprivation, illicit drug use, or illnesses. So my question is, what type of seizure did our patient experience? Based on her husband's description of the oral and manual automatisms, we deduced that it was likely a focal onset. Those features often come from temporal lobe or frontal lobe seizures. The hand manual automatisms, try to imagine that, most often occur from seizures from the left temporal lobe. That focal onset seizure likely spread to both sides of her brain when she had the shaking in the car. So we'll call the phenomenology for her seizure a focal onset seizure with spread to a generalized tonic-clonic seizure. Do you think she has epilepsy? Hold that thought. In order to answer that question, we need to discuss the definition, classification, and etiologies of epilepsy. Not all seizures mean epilepsy. In fact, the majority of first onset seizures do not go on to the patient having epilepsy. A single new onset seizure that's unprovoked has a less than 10% chance of recurrence. You may remember from that prior slide that about 1 out of 10 people will have a seizure in their lifetime. However, about 1 out of 30 people will actually receive a diagnosis of epilepsy. So let's talk about definitions. The old definition of epilepsy was that the person experienced 2 unprovoked seizures or more, with at least 24 hours separating those seizures. In 2014, this definition was revised so that the person simply had to have 1 unprovoked seizure, and they had to have another feature from their clinical history or testing supporting a high risk of having another seizure, which means that they would have at least a 60% chance of getting another seizure in the next 3 to 5 years. This next slide here shows the curve incidence of epilepsy. The y-axis shows the rate of epilepsy per 100,000 patients. The x-axis shows age in years. As you can see, epilepsy is much more common in the first 6 to 12 months after birth to about 20 years old. Then it starts to plateau in the 20s to 30s, which is a much more common time for MS or migraine onset. And then the risk again starts to rise after about 50 years old. At that time, new structural lesions such as strokes, brain tumors, and head trauma may be the cause of people having epilepsy. So this curve is U-shaped. This next slide here shows classifications of epilepsy. The basis for that is knowing the patient's seizure type. Focal seizures cause focal epilepsy. Generalized seizures cause generalized epilepsy. Rarely, patients may have focal and generalized seizures. In that case, we call them combined epilepsy. Epilepsy syndromes are the most precise way of categorizing epilepsy. That's based off of the age of onset, the seizure types, the EEG patterns seen, and comorbidities such as cognitive impairment. Examples of epilepsy syndromes are childhood absence epilepsy, juvenile myoclonic epilepsy. Epilepsies may also be classified by their cause. Many of the causes are structural, such as vascular lesions such as an AVM or an old stroke, tumors, encephalomalacia from a head trauma, infectious, meningitis or encephalitis, immune-mediated epilepsies such as autoimmune encephalitis, and in degenerative conditions such as Alzheimer's disease. Less commonly, causes are genetic and metabolic. Okay, let's take a look at some examples of structural causes of epilepsy seen on MRIs. This first image on the left is an MRI without contrast. It's a flare sequence. That's basically a T2 with the CSF removed. Imagine that the patient is looking directly at you. The cuts are through the coronal plane, through the hippocampi, which is commonly known as an epilepsy protocol MRI. Notice the difference between the left and the right mesial temporal lobes. Does that arrow help? The left hippocampus is atrophic and has increased T2 signal as compared to the right side. Also, the hippocampal layers are not easily seen on the left as they are on the right. These features are radiographic features for mesial temporal sclerosis, or MTS. The second image is a similar MRI flare sequence. However, now it's in the axial plane with the patient looking towards the top of the slide. Do you notice any differences or problems? What it's pointing to is a T2 hyperintensity in the left occipital lobe. It's a focal cortical dysplasia. Basically, that's a congenital abnormality of brain development where neurons fail to have proper migration. Both that first MRI and the second MRI are examples of pathology that often escape CT imaging but will show up on MRI. Finally, this last MRI is a T1 axial sequence, but this time with contrast. There's an enhancing right frontal mass. In this case, it's a glioblastoma multiforme. That's the highest grade glioma. This next slide has more examples of structural causes of epilepsy. The leftmost image is a non-contrast head CT. The axial cuts show a well-defined wedge-shaped hypodensity in the right frontal lobe. That's a chronic right MCA stroke. The next series of MRIs are in the axial plane showing neurocysticercosis, a tapeworm infection. There's a focus of enhancement on the T1 image with gadolinium with a surrounding hyperintense edema on the FLAIR image. And that last sequence, the CAT scan, shows a hyperdense calcification. Basically, the tapeworm head is being imaged here. Suckers, hooks, and all. Neurocysticercosis is a leading cause of epilepsy worldwide. Okay, now that we took a second to get that terrible image out of our minds, let's get back to the case. Our patient and her husband ask about the chance of future seizures. They also want to know treatment options. What would you advise them? This is a perfect time to discuss diagnostic testing for seizure recurrence risk. As we mentioned before, seizures can be provoked or unprovoked. That is a very important topic. Common provoking factors include drugs. They can be illicit drugs such as cocaine, ecstasy, and some forms of synthetic marijuana. They can be prescription medicines such as tramadol, a pain medicine, clozapine, an antipsychotic, or bupropion, an antidepressant. Seizures have been reported when these medications are first started in patients or when the doses are significantly increased. Drug withdrawal is another cause of seizures that are provoked, such as alcohol withdrawal or benzodiazepine withdrawal. Fever is another cause for provoked seizures. This is an important point. Febrile seizures often happen between 6 months and 5 years of age. Other causes for provoked seizures are extreme sleep deprivation, metabolic causes such as low glucose, low sodium, or low calcium. Another cause for provoked seizures is eclampsia. Finally, neurologic illnesses such as stroke, meningitis, encephalitis, or a traumatic brain injury when the patient is in their first 1 to 2 weeks of that illness are causes of provoked seizures. These are also called acute symptomatic seizures. Only about 1/5 of patients with these acute symptomatic seizures will go on to have epilepsy. Workup for risk of recurrent seizures with these patients is variable. It often depends on what the provoking factor was, how often that provoking factor has occurred with or without seizures, and how much resources the healthcare environment has. Now let's move on to unprovoked seizures. Those kinds of seizures definitely deserve extra attention for risk of recurrence. You should work those up. Our patient had 2 complex partial or non-convulsive seizures, and she had a generalized tonic-clonic seizure in the car. What do you think her risk for recurrence is? It is high. It's about 80% or more. So we would advise her to take a seizure drug and to get a more advanced epilepsy workup to determine why she has epilepsy. This next slide here shows aspects of clinical history that we attend to when understanding about seizures. Get a description from a bystander when possible. The patient may often not know what has happened in their seizure, especially when they've lost awareness. It's often helpful to ask the patient if they've had other events possibly due to seizure, such as an unexplained car accident or unexplained falls. Other features to pay attention to are age of onset. That can help you understand what epilepsy syndrome they have. For example, children with absence epilepsy typically occur between 8 and 12 years of age for their first seizure. A seizure happening from sleep at night is much more likely to be an epileptic seizure as opposed to another type of event such as syncope. The duration of the event is important. As we discussed, most seizures are 1 to 2 minutes long. About 1/3 of women with epilepsy have worse seizures around the time of their menstruation or around the time of ovulation. We had talked about seizure triggers before. One should ask about epilepsy risk factors. We discussed many of them when talking about structural causes for epilepsy. Other risk factors for epilepsy are prior febrile seizures, developmental disorders such as autism, and learning disorders such as dyslexia. Now let's move on to the physical exam. In patients with focal onset seizures, you especially should have a good neurologic exam to look for focal deficits. Examining a patient after their seizure should also include looking for signs of injury. We talked about tongue laceration. You can see an example of a lateral tongue bite in this picture here. You should look for broken bones, signs of dislocation. Uncommonly, there are neurocutaneous syndromes such as neurofibromatosis type 1 that also have epilepsy. This cafe au lait spot seen in a patient with NF1 is an example of a skin finding in a patient with epilepsy. Now let's move on to objective testing. All patients get routine labs, including a calcium and a sodium. If a patient's on a seizure drug and they've had a recurrent seizure, we'll often get an anti-epileptic drug level. A toxicology screen is done when an illicit substance is a concern. In neuroimaging, most patients that present to the ER with a seizure will get a CAT scan. It's a good test to look for large abnormalities such as hemorrhage or large tumors with edema. As we had mentioned before, the MRI is much more sensitive for picking up causes of pathology for focal onset seizures. In select situations, we'll get a higher resolution MRI, a 3 Tesla MRI. We do this especially when looking for causes of epilepsy that need a surgical intervention. The routine EEG is typically a 20 to 30 minute recording of brain activity to look for epileptiform discharges. Those are abnormal waveforms that occur in between seizures. Unfortunately, a single routine EEG has poor sensitivity. About 20 to 30% of patients that have epilepsy will have a significant abnormality on that first routine EEG. If you cannot get an explanation from that routine EEG, you can do future EEGs that are longer to increase the sensitivity. More on EEGs in a moment. Finally, lumbar punctures are rarely considered in working up a seizure. You should think about them when the patient has immunosuppression or when you're suspecting a CNS infection such as meningitis or encephalitis. Now let's move on to EEG. Here's a typical 12-lead EEG recording. Before you have a panic attack looking at these squiggly lines, let's get you oriented. No, you do not need to know how to read an EEG, but you should have some appreciation for how we use it. The picture on the left shows how the electrodes are placed on the head. The letter markings correspond to the lobes, F for frontal, FP for frontal polar in the front of the head, P for parietal, T for temporal, and O for occipital. The Z after some of the letters means midline electrodes. Those midline electrodes are the FC, CZ, and PZ, as you can see in the center of that image. The odd number electrodes are the electrodes on the left side of the head, and the even number electrodes are the ones on the right. Now let's look at the EEG recording for our patient. What we see here is a typical 15-second snapshot of an EEG from sleep. The green lines separate the EEG into 1-second segments. The x-axis is time and y-axis is voltage. The first set of the 4 squiggly lines correspond to electrodes on the left side of the head on the lateral side. The third set correspond to the left hemisphere electrodes near the midline of the head. The next set and the last set of 4 lines is the same set of electrodes but on the right side of the head. Those last 2 lines are the FC, CZ, and PZ midline electrodes. The box in this EEG denotes a spike or epileptiform abnormality. In this case, the spike here is from the left temporal lobe. Finally, our patient's MRI is depicted on this image here. To refresh your memory, this is a T2 coronal slice through the hippocampi. The patient's looking at you with the patient's left on your right. Can you see an abnormality? I hope you noticed the hyperintense atrophic left hippocampus, which is a sign of left mesial temporal sclerosis. Do you remember where that spike or epileptiform discharge was on the patient's EEG? That's correct. It was on the left side in the left temporal lobe. So the EEG and MRI correlate. The world makes sense. So let's put together what you've learned in the last few slides. This slide here shows factors that increase the risk of a patient getting future seizure after they have had their first seizure. The clinical history of a developmental disorder like autism, neurologic exam abnormalities on your physical exam, historical event that can injure the brain, such as a loss of consciousness after a head trauma. The MRI finding that has, for example, mesial temporal sclerosis, as in our case, or anything else where the cortex is of issue, is a strong risk factor for a recurrent seizure. Please note that the T2 white matter abnormalities around the ventricles that a lot of patients have, that's not a risk factor. EEG is a clear risk factor. The epileptiform discharge, which is in the reports termed spike or sharp wave, is what you should look for. And again, we talked about the first EEG, which is often a short one, is not as sensitive as future EEGs and longer EEGs. So if you have any one of these risk factors depicted in this slide, your risk is more than 60% of getting a second seizure in the next 5 years. These risk factors also help appreciate the new definition of epilepsy that we talked about before, which is having one of these clinical features clearly increases the risk, and that patient now is viewed as having epilepsy even with that one unprovoked seizure. Lastly, there are some weak risk factors. A seizure from sleep and genetic findings and family history is a weak risk factor. Okay, so I'd like to go back to our case and have you help me decide on management. To summarize, our patient's MRI showed left mesial temporal sclerosis. The interictal EEG had left temporal spikes, which are epileptiform discharges. She was diagnosed with epilepsy of the left temporal lobe from mesial temporal sclerosis, which is a focal epilepsy with a structural supporting feature. And her husband and her want to know what they should do for treatment. What would you do? Let's move on to treatment. Like anything in medicine, we should weigh the risks and benefits. The key here is preventing consequences of having seizures. There is seizure-related injury. We've spent a lot of time talking about broken bones, dislocations. There's also a term SUDEP, sudden and unexpected death in epilepsy patient. A patient will have a generalized tonic-clonic seizure, and in the next 15 minutes, they will die. The best study was done in patients in epilepsy monitoring units who were allowed to seize on purpose for medical diagnostic purposes. And what happened was, for about 20 patients, they had decrease in breathing or slowing of their heart rhythm, and they had a cardiopulmonary arrest. This risk is rare, about 1 in 1,000, or 1 in 100 patients per year in uncontrolled epilepsy. There are other neurologic changes that can happen with repeated seizures. Some patients can have cognitive decline. Some seizures can actually make a patient zone out in that event, so acting demented. I've had one patient who had repeated seizures where he would stop paying attention, not be able to talk, lose track of time. It happened so much that people thought he was becoming demented. Once we successfully treated him, these changes weren't perceived anymore, and actually detailed cognitive testing showed improvement in scores. Repeated seizures is linked with higher rates of depression. Repeated seizures also affect people's social function. They can't drive, they are restricted in jobs, they can't swim. So clearly you see there are benefits in preventing seizures for patients. However, on the other hand, there are side effects with the medications. Up to about 20% of patients that are started on a seizure drug cannot tolerate that seizure drug. Some of the most common side effects from seizure drugs as a whole are disequilibrium, cognitive slowing, dyspepsia, weight gain or weight loss. Even less common are side effects such as liver dysfunction and blood cell suppression. The next slide shows the progress we've had in seizure drug development. For about 100 years, we've had therapies such as phenobarbital, and as you can see from this slide, we've had about 25 seizure drugs brought to the market. It seems like there's an anti-epileptic drug for every mood and season. I know what you're thinking. Why are there so many seizure drugs? What we found is that the efficacy is similar. However, in general, the seizure drugs that have been developed in the last 20 years seem to have less side effects and more tolerability, especially for long-term side effects such as with phenytoin having gingival hyperplasia or ataxia and cerebellum shrinkage. These findings are not seen in newer seizure drugs. The next slide here is a cartoon of how seizure drugs work. They work with two basic principles. They increase inhibitory effects or they decrease excitatory effects at the synapse. Presynaptic calcium channels are targets for gabapentin and pregabalin. Vigabatrin is a drug that increases GABA concentrations at the synapse. Benzodiazepines increase GABAergic effect on the chloride channels. Moving on to the drugs that affect excitation, the sodium channel is a very common target for seizure drugs. You can see phenytoin and many other drugs having an effect there. The drug levetiracetam actually works to decrease the intracellular transport for glutamate. The postsynaptic AMPA receptor is a target for topiramate and perampanel, and there are also calcium channels and NMDA receptors that are affected by retigamine and felbamate. Clearly, this is a very complicated topic and you don't need to memorize, but the basic concepts, again, I want you to understand is drugs work by increasing inhibition, decreasing excitation. Another thing you should take from this slide is the mechanisms of actions help guide us in prescribing. There's more on that later. This slide here shows common principles we use when prescribing a seizure drug. The main factor we consider is the patient's seizure type and epilepsy type. Other things that we consider are side effects of the drugs. For example, if a patient already has a disorder such as kidney stones and a drug's known side effect like topiramate for kidney stones exists, we would be less likely to make that a top choice for that patient. Another factor that we consider is comorbid conditions. Sometimes we can kill two birds with one stone. So for example, if the patient has uncontrolled epilepsy and migraines that are uncontrolled, topiramate is helpful for both of those, and we would consider that as a drug for that patient. Hopefully they don't have kidney stones. Another thing that we consider is drug interactions. You may recall from your pharmacology days that some of the seizure drugs are enzyme inducers, such as phenytoin and phenobarbital. These drugs can have a negative effect on the efficacy of chemotherapeutics, antiretrovirals for patients with HIV, and warfarin. Contrary, some drugs have inhibitory effects on the liver metabolism, such as valproic acid. So if the patient takes valproic acid and warfarin, then they can have problems with bleeding. Another factor that we consider is titration time. This is especially important when the patient's having frequent seizures. We would pick a drug that would be easier to titrate faster. Levetiracetam is an example of that. We would not pick lamotrigine in that case because it typically takes 1 to 2 months to make that drug therapeutic because of a slow titration schedule. Other things we consider are formulation and cost. A good rule of thumb to have when dosing a drug for a patient is start with a low dose and go slow in your titration. Speaking of side effects, we talked about common adverse effects, and it's worth noting briefly serious ones. The picture on the left shows Stevens-Johnson syndrome, which is clearly a serious adverse event when starting many of the older seizure drugs such as phenytoin, carbamazepine, and phenobarbital, and also lamotrigine, a newer seizure drug. Typically, rashes start in the first 1 to 2 months of starting a seizure drug, and that's also the same time frame for Stevens-Johnson syndrome. It's a diffuse rash that has a painful blistering in the skin, and the patient's mucosa, for example in their mouth, also starts to desquaminate, and they often have to get treatment as a burn victim would. Please note that this is a very rare occurrence. It's less than 0.1%, and it can be further decreased by starting the drug at a low dose and titrating up slowly. Bone marrow failure is another side effect, such as aplastic anemia in felbamate and also in carbamazepine. Mood changes are associated with some of the seizure drugs. For example, levetiracetam and perampanel can make depression worse or make psychoses occur. Hyponatremia can happen with carbamazepine and oxcarbazepine. An uncommon used drug is vigabatrin. That can cause irreversible visual field defects. That's a reason why it's a last-line drug. When we do use that, we get visual field testing periodically to look for that. As you can see from this slide, the number of seizure drugs is daunting, but we have an organized approach to drug selection. The rows highlight various seizure types, and the columns highlight monotherapies on the left column, second-line therapies, and the last choice alternatives. The broad spectrum drugs are marked with an asterisk. Broad spectrum refers to drugs that work for many seizure types. They work for partial onset seizures or generalized tonic-clonic seizures from a focus, and they also work for many of the generalized seizures, such as generalized tonic-clonic seizures. Levetiracetam or Keppra. It's commonly used as a first-choice seizure drug. Because of it being broad spectrum and also that it has a relatively safe profile, again, this table is a good table to use as a reference. Even epileptologists do not use all of these drugs, and I have a handful of favorites for particular uses. So let's get back to our case. Our patient continues to have rare non-convulsive seizures, and she's on lamotrigine and levetiracetam. She wants to get pregnant, and she asks for guidance regarding her AEDs to use. What would you advise her? This is a somewhat challenging question that the patient asks their neurologist, especially since seizures worsen in about a third of women during pregnancy, and quality safety data is generally lacking. Most of the data comes from safety registries, which is a far cry from randomized controlled trial data that we want. The bottom line is that lamotrigine and levetiracetam have the best track record in pregnancy. Our patient is a woman of childbearing age, and it's not a coincidence that she was treated with those two agents. Let's pat ourselves on the back for a job well done. We still want to decrease her risk by including folate supplementation. I typically will have the patient take an extra folate tablet to get about 1 milligram of folate into them per day. On the other hand, valproic acid is the worst teratogen and has about a 10% chance of causing a major malformation or autism spectrum disorder in a baby. Phenobarbital has been associated with lower childhood IQs, and topiramate has a low but significant risk of causing a cleft lip or cleft palate. So, in women trying to get pregnant, say yes to levetiracetam and say no to valproic acid, and don't forget the folate. This next slide here illustrates a final important point I want to highlight about anti-epileptic drugs. It's the phenomenon of diminishing returns. In a patient with epilepsy, the first drug chosen and dosed to a medium or high level provides seizure freedom in about half of the patients. By adding another drug, we'll help about 20% more of those uncontrolled patients. By the time you have 3 drugs tried, your chance of seizure freedom is quite low. It's less than 5%. These patients are labeled medically refractory epilepsy patients. Let's get back to our patient. 2 years after her delivery, she unfortunately continues with uncontrolled seizures. In fact, they're worse. She has medically refractory epilepsy. Her neurologic exam remains normal. What would be your next best step for her management? When drugs fail, a common intervention we consider is epilepsy surgery. Fun fact, we have been doing epilepsy surgeries, quote-unquote, off-label for centuries. Here are some paintings from the 12th and the 15th centuries. The procedure was called trepanation, and it basically involves making a burr hole in the skull. Looks barbaric, doesn't it? We actually have some current-day experience with this. We've had some patients who've had implants of electrodes put under their skull surface to record EEG during intracranial EEG monitoring. Some of those patients who seize several times a week before this implantation actually become seizure-free temporarily after the implantation and after the electrodes are removed. This may be what the trepanation had caught on to. More standard procedures for patients with uncontrolled focal epilepsy have been done for several decades, such as the temporal lobectomy. In 2001, we got some high-quality data. The results are shown on the plot here. The y-axis shows percentage of patients without seizures. The x-axis is months. It's quite clear that temporal lobe surgery is superior to medical management. The number needed to treat was about 2. It means that for every 2 people that undergo epilepsy surgery, 1 is cured. The picture on the right shows the amygdala, the hippocampus, and portions of the anterior temporal lobe that are removed in such a surgery. Patients have typically little to no side effects, and they have a marked improvement in quality of life. This next slide here shows other treatments that we have for patients who remain medically refractory. A new option is minimally invasive epilepsy surgery called stereotactic laser thermal ablation.
You know, I have one simple request, and that is to have sharks with frickin' laser beams attached to their heads. Now, evidently, my cycloptic colleague informs me that that can't be done. Can you remind me what I pay you people for? Honestly, throw me a bone here. What do we have?
It's been done since the year 2000, and in fact, Robert Wood Johnson University Hospital is a leading site for this procedure. This video shows a hippocampus in the patient's left temporal lobe being ablated. The MRI images are capturing heat changes that occur in the brain tissue during the ablation. The red and the yellow colors show temperature changes in excess of 70 degrees Celsius. Other options for epilepsy surgery include brain and vagus nerve stimulation. The picture here depicts the device called RNS, or responsive neurostimulation. It's a computer chip that's carved into the patient's skull with electrodes that are inserted under the skull surface into the brain tissue, and they stay in the patient's head for the rest of their life. The electrodes will sense seizures and they'll stimulate when they occur to abort the seizure without disrupting the patient's function. Another option is ketogenic diet. It's a diet that's typically done in children. It's a diet that's high in fat and protein and has very little carbohydrate. It can lead to a dramatic improvement in seizure control, but it's a diet that's very hard to adhere to for adults and for the long term. Can you imagine not having ice cream, pasta, or any other carbohydrates? And finally, another new option for epilepsy is the drug called cannabidiol. Cannabidiol, or CBD, is a chemical that comes from the marijuana plant. And you thought that epileptologists don't know how to have fun. It's been studied in a handful of randomized controlled trials in patients with the most severe types of epilepsy. The CBD works roughly as good as other seizure drugs. Our patient underwent laser ablation and remained seizure-free for 2 years after that procedure. She's actually been able to reduce her seizure drugs to 1 at a moderate dose. All's well that ends well. So we come to the conclusion of our journey together. Here are a few important points. First, new onset seizures require a careful history from the patient and witness. The devil is in the details. Next, not all seizures mean epilepsy. Thirdly, provoked seizures are less likely to recur, but unprovoked seizures need a thorough risk stratification and workup. Fourthly, MRI and EEG, although having low sensitivity for all patients with epilepsy, can help you risk stratify for future seizure risk recurrence, and they can define the epilepsy type. Next, AED selection. Start low and go slow. Levetiracetam is a good low-risk drug for most epilepsy types. In women of childbearing age, avoid valproic acid. Lastly, some patients with uncontrolled seizures may be helped by epilepsy surgery. Thank you very much for your attention. Bye-bye.